Let us start the session today. The topic is acute renal failure, and the speaker we have today here is Dr. Nikhilesh Jain, who is the Director and Operational Head Depth of Critical Care Services Care at CHL Hospital, Indore. Thank you, sir, for being with us. You can take over the class.
So, over the course of next 30 to 40 minutes, I hope to cover a major part of this important topic, that is acute kidney injury. And let's see how it works out. Uh, so, why is acute kidney injury important? It's a syndrome which is characterized by a rapid deterioration of kidney function. By rapid, I mean hours to days. And there will be certain clinical consequences of AKI, which will include the accumulation of waste products, electrolytes, and fluid, but also less obvious effects, such as lowering of immunity and dysfunction of non-renal organs, what we all commonly call as organ crosstalk. There's a very good amount of increasing evidence that acute kidney injury is actually associated with serious short and long-term complications, in particular, increased morbidity and mortality. So when we talk in terms of defining or labeling a patient as acute kidney injury, what are your diagnostic and definition based cutoffs that you want to use? Uh, am I audible? Am I audible?
Yes, sir, you are audible.
Okay. So the common ones that we use are rifle, Akeen, and there would be one more score KD go that would come later on in the course of the presentation. So rifle, in that we actually define RIF, that is serum creatinine increased to 1.5 fold, or a GFR decrease of more than 25% from baseline. This is the serum creatinine criteria. I is the injury part, that is serum creatinine increases to twofold or GFR decrease of more than 50% from baseline. Then F is failure, wherein you get a serum creatinine increase to threefold, a GFR decrease of more than 75% from baseline, or a serum creatinine of more than or equal to 354 micromole per liter, that is more than 4 milligram per deciliter, with an acute increase of at least 0.5 milligram per deciliter, at least 44 micromole per liter. On the other hand, you have the urine output criteria, which is less than 0.5 mils per kg per hour for 6 hours. Again, which is less than 0.5 mils per kg per hour for 12 hours for eye or injury part. And for failure, it is less than 0.3 ml per kg per hour for 24 hours, or a proper inuria for 12 hours. When it comes to Akin score, you divide it into various stages, stage 1, 2, 3. So stage 1 is again a serum creatinine increase of more than or equal to 0.3 milligram per deciliter, or an increase to 1.5 to 2-fold from baseline. Stage 2, you get a serum creatinine increase to more than 2-fold to 3-fold from baseline. Stage 3, you get a serum creatinine increase of more than 3-fold from baseline, or a absolute serum creatinine value of more than or equal to 4 milligram per deciliter, with an acute increase of at least 44 micromole per liter, that is 0.5 milligram per deciliter. And when we use that for urine output criteria, so urine output criteria remains the same whether you are using the rifle score or the Akin score. So points to remember whenever you talk about acute kidney injury are: oliguria will actually precede your rise in serum creatinine. Anuria can be taken at 50 mils per day. Once you've detected it in a patient, you should look for any reversible causes. In general, non-oliguric AKI has a better prognosis. There's only one publication which actually does not favor this point. And recognition of non-oliguric patients is very important, as they may require, the statement that I'm using is may, so they may require early dialysis. And longer the oliguria, more is the mortality and more is the severity of the injury. Now, whatever scoring systems we use, they actually help in prediction of mortality and sometimes the further course of the acute kidney injury. So if you have a patient who's got suspected oliguria or anuria, you need to do an hourly monitoring of urine output. You need to assess the catheter position and patency, examine if there's any palpable bladder, look for any flushing, if there is any flushing of catheter that may be required. Establish if there are any mechanical reasons because of which you are getting oliguria and anuria in this particular patient, and try to look for any other causes which can be causative for acute kidney injury. So how do I diagnose it? So this is the KDIGO definition and classification. This is one of the most widely accepted. So in this, the diagnostic criteria would be acute kidney injury would be defined as any of the following, increase in serum creatinine by more than or equal to 0.3 milligram per deciliter within 48 hours, or increase in serum creatinine to more than or equal to 1.5 times of baseline, which is known or presumed to have occurred within the prior 7 days, or a urine volume, absolute urine volume of less than 0.5 mils per kg per hour for 6 hours. Then you have a staging system. If you're talking about AKI stage, then you can use again serum creatinine criteria and urine output criteria. So acute kidney injury stage 1, again increase of serum creatinine by more than or equal to 0.3 milligram per deciliter, or increase to 1.5 to 1.9 times from the baseline. If you've got stage 2, then you get an absolute increase in serum creatinine to 2 to 2.9 times from baseline. If it is stage 3, then you get an increase of serum creatinine of more than or equal to 3 times from baseline, or an absolute value of serum creatinine more than or equal to 4 milligram per deciliter, or this patient requiring a renal replacement therapy, or in patients who are less than 18 years of age, the decrease in estimated GFR is to the tune of less than 35 mils per minute per square meter of body surface area. When it comes to urine output criteria, you've got a urine output criteria of less than 0.5 mils per kg per hour for 6 to 12 hours. Then it is less than, for stage 2, it is less than 0.5 mils per kg per hour for more than or equal to 12 hours. For stage 3, you have less than 0.3 mils per kg per hour for more than or equal to 24 hours, or the patient is frankly anuric for more than or equal to 12 hours. However, you have problems with serum creatinine. Now, I would be touching this problem with serum creatinine again and again just to drive the point home. So, serum creatinine is synthesized from glycine and arginine in liver, kidneys, and pancreas, and it serves as a reserve for phosphate in muscle. Then it is determined by amount of creatine generated in liver, pancreas, and kidneys, ingested creatine, and muscle function. It is freely filtered by the glomeruli, and if it is healthy, if the person is healthy, it is produced and excreted at a constant rate. So what you are getting is a secretion of creatinine in the body per se, and half-life of the same compound increases from 4 hours to 36 hours in those patients who have renal impairment along with decreased GFR. If you've got patients who have got severe sepsis, who have got liver disease and muscle wasting, then this creatinine is not reflective of fall in glomerular filtration rate, or it does not go hand in hand with glomerular filtration rate. So when we talk in terms of potential pitfalls of AKI diagnosis, which are based on creatinine and urine criteria, so you can get clinical scenarios in which administration of drugs has been done, which interfere with the tubular secretion of creatinine. So you may get a higher value, such as cimetidine and trimethoprim, and then you can get decreased production of creatinine in patients who have liver disease, severe sepsis, or muscle wasting. Then certain times there can be ingestion of substances which lead to increased generation of creatinine independent of renal function. That is an oral ingestion of creatine or cooked meat. Then obesity, you can overdiagnose acute kidney injury if you're using actual weight when when you're actually applying the urine output criteria. Then conditions which are conventionally associated with physiologically increased GFR, such as pregnancy, wherein you may get a delayed diagnosis of acute kidney injury. Then certain times you may have certain chemical substances which will interfere with the labs, with the actual analytical measurement of creatinine. It is done by Jaffe method. So there can be certain common compounds such as 5-fluorocytosine, increased bilirubin levels, wherein it can lead to misdiagnosis. Then those patients who have undergone fluid resuscitation and are currently in overload, So in these patients, there may be a dilution of serum creatinine concentration and there may be a delayed diagnosis. There may be those patients who have got a progressive chronic kidney disease with a gradually increasing rise in serum creatinine. They may be misdiagnosed as acute kidney injury. Extrinsic creatinine administration as a buffer in medications, as it happens in patients who receive IV dexamethasone or azacetrol, wherein it is referred to as a pseudo-acute kidney injury, or there may be oliguria due to acute temporary release of ADH, that is post-operatively nausea, pain, which is enhanced by maximal sodium reabsorption in the setting of volume or salt depletion, which leads to a misdiagnosis of acute kidney injury. So this is how the generation and clearance of creatinine happens. It's a schematic. It is just a schematic diagram about how it cycles through the liver, kidney, muscle, and the systemic circulation. To add to the above points, the creatinine concentrations may take 24 to 36 hours to rise after an insult. And as I discussed before, there are no standardized lab methods for quantifying the same. There is something called as Jaffe method, but which can vary in different cutoffs and along with the interference of different compounds. Now, if you have a creatinine-based criterion, it actually does not identify your renal reserve. So you never get to know how much of residual kidney function is left. It does not make us any wiser regarding the etiology of the acute kidney injury and does not tell us whether the patient is in a progression phase or a recovery phase. So our objectives today would be recognition of an anuria patient, trying to reach a diagnosis, looking for causes and attempting to treat the same. There are certain historical points in this, William Heberden, who mentioned conventionally ischia renalis in 1802. Then there have been other terms which have been used interchangeably, war nephritis, Cush syndrome, wherein rhabdomyolysis leading to AKI was referred to this. Then Homer, who actually described it as acute renal failure uh, Homer, who actually described it as acute renal failure in 1951. And then we talk about nomenclature in terms of acute kidney injury, how it has evolved further. So what are the categories of acute kidney injury? You get a pre-renal versus intra-renal versus a post-renal paradigm. So common causes of pre-renal causes of AKI include dehydration, heart failure, which is also known as cardiorenal syndrome, and liver failure, also known as hepatorenal syndrome. Then you get intrinsic renovascular diseases, that is intrarenal, such as hypertensive emergencies, vasculitis, thrombotic thrombocytopenic purpura, and inoxion and HUS, hemolytic uremic syndrome. Then glomerular disease in the form of post-infectious glomerulonephritis, tubular interstitial disease in the form of acute tubular necrosis, and cause can be variable. It can be drug-induced, it can be because of sepsis, it can be sometimes be contrast-induced. You can get rhabdomyolysis, or there may be a prolonged pre-renal acute kidney injury which has actually led to intrarenal damage now. And of course, acute interstitial nephritis, which can have a host of causes. Then when we talk in terms of post-renal, it can be either because of a mechanical obstruction in the form of a ureteral obstruction, a neurogenic bladder, sometimes urinary tract infection, some certain medications, and of course, benign prostatic hypertrophy leading to bladder outlet obstruction. So there are certain points that we should remember here. If oliguria or anuria continues beyond several weeks, severe ATN or cortical necrosis should be suspected. If hypoperfusion is prolonged, tubular damage results. I'll be coming back to it again and again. In most of the oliguric cases, the cause is pre-renal, 55 to 60%. And if you think that this is pre-renal, then trial of resuscitation, including giving volume, should be attempted. If the hypoperfusion, as discussed before, is uncorrected, it can actually keep on aggravating the renal insult. And early fluid resuscitation with targeted hemodynamic endpoints may be worthwhile. So there are certain caveats on fluid resuscitation that we should remember. Now, if you go for a very aggressive fluid resuscitation, nowadays it is associated with increased mortality. So the idea is to give right amount of fluid rather than keeping your patient wet or dry. And we need to embrace newer parameters of fluid resuscitation. Of course, the discussion of that would be beyond the realms of today's lecture. And there is a need to switch over to passive leg raising or IVC distensibility, depending on the situations that you find your patient in. So the common consequences that can happen, cerebral edema, pulmonary edema, myocardial edema, hepatic congestion, along with renal swelling, tissue edema, and gut edema. Now, all these are sequelae of aggressive fluid resuscitation. Choice of fluids, normal saline is unphysiologic. We all know that normal saline is abnormal because of the osmolality and chloride related issues. So normal saline is preferred choice for physicians, whereas ringer lactate is preferred by surgeons for reasons which are actually unknown and undocumented in the literature. Now, ringer lactate can be infused in the same venous line as blood, whereas a chloride liberal fluid, in this case, it would be referring mainly to normal saline, is associated with higher chances of renal failure as compared to a chloride conservative fluid. Hypochloremic acidosis, of course, if your chloride concentrations are up, remains a risk. And if you're thinking that giving RL in patients of renal failure, there may be problems. So do remember that hyperkalemia related death, even in patients of renal failure who've been receiving ringer lactate, it remains unreported till date. So we'll have a small case vignette, reference is given for a 62-year-old female, status post-op for bariatric surgery. This patient has received a total of 20 liters of fluid post-op in 3 days, and she remains oliguric. Now, creatinine levels have gone up from 0.5 milligram per deciliter to 1.5 milligram per deciliter. So when we look at the workup, the hemodynamics remain decent. You haven't got any central line here. You do an echo, which is non-contributory, but you do a Bun creatinine ratio. And do remember that a Bun creatinine ratio, if it is more than 20, is pre-renal, and less than 10 to 15 is most likely to be renal or intrinsic AKI. And what about urine parameters? So when we talk in terms of pre-renal uremia vis-a-vis acute tubular necrosis, that is pre-renal versus intrinsic damage to the kidneys. So urine sodium or urine chloride, whatever way you want to call it. So in pre-renal, it is urine sodium is less than 10, whereas in acute tubular necrosis, it is more than 20. Urine chloride levels remain more or less the same, in the sense that pre-renal uremia is less than 15, but for ATN, it is more than 20. FeNA or fractional excretion of sodium. With pre-renal, it is less than 1%, whereas with acute tubular necrosis, it is more than 2%. Urine osmolality is more than 500 milliosmoles per kg conventionally, if you're talking about a pre-renal uremia. And for acute tubular necrosis, it is within the range of 300 milliosmoles per kg. Now, what if my pressure heads are not good? I told you about the perfusion part. If you've got a low renal perfusion, patient goes into hypovolemia, patient goes into cardiogenic, either because of a cardiogenic shock, this can happen. Then it can happen wherein you get a concurrent myocardial dysfunction, valvular dysfunction, and tamponade. Then in those situations where you have excessive peripheral vasodilatation, such as sepsis, cirrhosis, and anaphylaxis, then of course renovascular causes such as renal vasoconstriction and certain drugs. So what are the differentials, for low urinary sodium or fraction excretion of sodium sometimes? So hepatorenal dysfunction is one, cardiorenal syndromes is other one, cyclosporin or tacrolimus toxicity is one, acute glomerulonephritis, contrast-related acute kidney injury, and of course uric acid nephropathy. The problems that happen with this approach is that elevated blood urea levels are always referred to as azotemia for all clinical situations. Now, uremia features pericarditis, encephalopathy, and bleeding manifestations, which can actually, require dialysis. If you want to diagnose hypovolemia, you need to have elevated serum osmolality, serum sodiums, along with hemoglobin levels. If you have a patient who's having a concurrent malnutrition or liver failure, serum creatinine may be low with a small muscle mass, and urea also may be low because of a slow protein turnover. Hyperkalemia and hyperphosphatemia will indicate a worsening kidney function. However, in those patients who are receiving diuretics, it is the fractional excretion of urea rather than FeNA which is more reliable. And what about urinary sediment? Value of casts in urine does not retain a significant value specifically for ICU patients, and there is a significant variability in microscopy and urine biochemistry indices. However, can be used for diagnosing acute tubular necrosis and predicting the further course of acute tubular necrosis. Now, what about my baseline serum creatinines? Going back to my earlier slides, it has got a very low sensitivity for renal dysfunction. The rising trends will actually lag behind your tubular injury. And as you have newer and newer scores coming up, lowering creatinine rise thresholds, sensitivity has improved in terms of diagnosing AKI. It is definitely influenced by changes in muscle mass, sex, race, certain drugs which can impact its value, body weight, drugs, sorry, it's a typo, and protein intake. Then there are certain novel biomarkers which remain investigational, such as IL-18, KIM-1, and of course, NGAL is one of them. What about other cases? When we talk in terms of intrinsic renal failure and acute tubular necrosis, you have history of sepsis, prolonged hypotension, drugs and nephrotoxin exposure. There can be a differential of glomerulonephritis here.
अंदर
Then you need to identify. Can I ask you to close the switch off the mic, please? Then you have to have a full clinical history with clinical examination in the form of a misplaced catheter, palpable bladder and suprapubic tenderness to identify the post-renal subsets. Confounding variables that can mislead you are confounding injuries, sometimes stupor or altered sensorium, intoxication, and of course, effect of sedative or anesthetic agents, which may be the case for ICU patients. What about post-renal patients? They may get altered sensorium, you may get bladder outlet obstruction, symptoms of prostatism, sometimes bladder discomfort, and of course, in trauma, in those subsets who have a concurrent pelvic and with or without urethral injury. To make points clearer, even small changes in serum creatinine, we are talking about more than or equal to 0.3 milligram per deciliter per day, or a percentage increase in serum creatinine to more than 50%, that is an independent predictor of mortality. Just a word about NGAL, which is a biomarker. It can be used for early diagnosis of acute kidney injury in subsets who have undergone cardiopulmonary bypass, certain subsets of contrast-induced nephropathy, patients have sepsis and post-renal transplantation. Early measurement can predict need of renal replacement therapy, mortality, and of course, the type of therapeutic response that you may get for early intervention. There are certain other investigations, namely ultrasound KUB, plain radiology. You look for CT scan to rule out pyelonephritis or nephrolithiasis. IV urogram along with retrograde and antegrade contrast studies, and of course, bladder pressure measurement for abdominal compartment syndromes. When it comes to medical therapy of acute kidney injury, see, the therapeutic part is small and actually the preventive part is huge when it comes to managing AKI in ICU patients. So first is, of course, going back to the original point, optimizing renal perfusion. You can give fluids, you can use vasopressors or inotropes, and of course, there may be certain selective renal vasodilators which you may like to use. Conceptual course of AKI, when we look at it, kidney function, how it goes in terms of a volume responsive AKI and a volume unresponsive AKI. So when we look at it, this is how it looks. Here you have the volume responsive AKI, and here you have got the volume unresponsive AKI. So in this, you are going from hypovolemia to euvolemia to hypervolemia. Okay. So here, common strategies to maintain renal perfusion in ICU. What do? You give a volume resuscitation or challenge, and depending on response of your cardiac index or mean arterial pressures, you need to have a mandatory increase. What is the type of targets that you are looking at? You are looking at a CVP of more than 5 to 8 or less than 12, of course, for hypervolemia. You looking at a map of more than 65 to 75 of mercury. You are looking at venous saturations of central venous oxygen saturation of more than 70% or lactates of less than 4. Early resuscitation after stabilization, once the patient is stabilized, please apply conservative fluid regimen even by giving high dose diuretics. If you have got certain at-risk patients and if you can monitor, do monitor the intra-abdominal pressure. Avoid artificial colloids, especially hydroxyethyl starch in sepsis subsets. In certain of these situations, albumin may be an alternative, but preferably use balanced solution. Currently, very doubtful evidence. Vasopressors, norepinephrine, which can be combined with vasopressin, especially for subsets with refractory shock. Inotropes can be used, such as levosimendan for acute heart failure or septic myocardial depression. Avoid nephrotoxin or nephrotoxic drugs such as aminoglycosides, NSAIDs, vancomycin, amphobees. So when it comes to treating your pre-renal acute kidney injury, you need to correct the cardiac output and improve the renal perfusion. You need to use fluid therapy. There's a note of caution which we have already told in terms of using starches and other plasma expanders that they worsen renal injury and lead to coagulopathic complications. There's a debatable use of vasopressors to optimize BP. What we use is NORAD, vasopressin, and adrenaline. I'll come to that somewhere later, again back in the PPT. And dopamine can actually increase your incidence of tachyarrhythmias, very unpredictable type of a drug. unpredictable effects, unpredictable physiological changes. So, in fact, even related to increased mortality now. And you can go ahead and use inodilators such as dobutamine and levosimendan. So these are the type of common IV fluids that we are talking about. What you have is the sodium chloride, sodium content, chloride content, potassium, calcium, bicarb, pH, and osmolarity. Now, if you see in this, actually the normal saline, that is the first row, is actually abnormal. And why it is called as abnormal? Because these type of sodium levels and chloride levels that you're looking at are supraphysiological, and it is not osmolar as well. Then we look at Hartmann solution, which is relatively closer, but look at the balanced solutions, plasma light. So here, what you have is osmolarity of 294, very close to the physiological part. And then sodium of 140 and chloride of 98, potassium of 5, 27 as in acetate, and a pH of 4 to 6.5. So again, not absolutely physiological when you look at the pH, but much better than what we talk about in normal saline. So what about dopamine? A lot of people harp on renal effects of dopamine. So leads to natriuresis, definitely yes. Increased cardiac output and heart rate, which leads to improvement in renal hemodynamics. So if you get an increased cardiac output and heart rate, that may happen with any other inotrope as well. So that can actually lead to natriuresis. But currently, there's no evidence to suggest that a dopamine-induced diuresis has any clinical benefits. What about diuretics? They have a role in management of hyperkalemia and volume overload, but no major clinical benefits and absolutely no effect on outcome of renal injury. Paradoxically, using diuretics can actually increase the mortality risk or lead to poorer recovery of renal functions, especially in those patients who are oliguric and who have diuretic resistance. Now, what about renal types? You can use immunosuppressives for glomerulonephritis. You treat the cause in the sense that you treat your sepsis, you treat rhabdomyolysis, abdominal compartment syndrome, tumor lysis syndrome, hyperuricemia, contrast agents, along with other nephrotoxic agents. Now, how do you treat post-renal? Transurethral catheterization, suprapubic catheterization, percutaneous nephrostomies, and of course, treating the abdominal compartment syndrome if you are able to document the same. Contrast related injury, control the risk factors, try to avoid nephrotoxic drugs and agents. Try to correct and avoid hypovolemia, especially if your patient is receiving concurrent diuretics. Please anticipate and apply preemptive volume expansion if feasible. Data for theophylline and iloprost is insufficient. You can still try out an acetylcysteine, but evidence is very poor, so probably I would not recommend it. Then there are other conservative measures such as avoiding the nephrotoxic agents. If you have any drugs which can cause interstitial nephritis, they need to be stopped. And try to maintain your sugars between 110 to 149 milligrams per deciliter. Ruling out physiological oliguria, it is seen very rarely. The common settings in which we see it is a post-cardiovascular surgery patient with high ADH levels. Ongoing use of therapeutic use of vasopressin may be there. We still need to rule out hypovolemia as a cause of this. What about outcomes? Early diagnosis and management improves results. You need to decrease the renal insults and contrast studies, prophylaxis while planning contrast studies. There's a huge debate on them, and probably we are coming to a point in time wherein we may say that either using minimal volume of contrast or even with contrast in acute kidney injury, probably these patients may not be incurring any major harm. Long-term results remain acceptable, and there are very high mortality rates for a concurrent acute kidney injury to the tune of 40 to 60%. So what about biomarkers? A lot of hype is there about biomarkers. So you have biomarkers at different stages of acute kidney injury. You have stress-related biomarkers such as NGAL, TIM2, and ILGF-BP7, as you can see here. Then you have injury biomarkers in the form of tubular cells in urine, glutathione transferase in urine, KIM1 and albuminuria. You've got functional loss biomarkers, wherein the markers commonly are cystatin C, rise in creatinine, and fall in urine output. And then you have recovery biomarkers, wherein you get a fall in creatinine, increasing urine output, decrease in NGAL, decreased cystatin, and of course, decreased injury biomarkers. So when it comes to prevention, as I discussed before, patient is at risk of clinical AKI. The variables that come into play are nephrotoxic drugs, older age, low GFR, diabetes, hypertension, cardiac failure, chronic liver disease. Of course, your elevated NGAL levels, KIM1, and elevated CCA biomarkers. Sepsis intervenes in between, and if you are able to treat sepsis early, if you are able to protect the kidneys early and remove the nephrotoxins, you can actually optimize the cardiac output, you can optimize the mean arterial pressure, maintain euvolemia, then it gets prevented. However, if there's delayed treatment of sepsis, if there is continued nephrotoxic exposure, you accept hypotension and low cardiac output, and you give suboptimal volume therapy, this evolves into a clinical acute kidney injury. There were various trials that were given in terms of PROMISE, PROCESS, ARRIVE, EGDT trials, which actually talked about a lot of fluid resuscitation, but they have failed consistently now. Noradrenaline plus vasopressin has been used in mild AKI successfully. Vanish trial has also been proven to be a failure. Now, when we look at injury pathways in excessive fluid resuscitation, now mind you, this becomes important. So these are potentially harmful pathways. And what really is happening there is you get a tissue edema in an encapsulated organ, you get osmotic nephrosis, and you get tubular dysfunction. So what is really happening here? You need to remember classic trial, which actually showed worsening of AKI with volume boluses. Then you need to know that balanced solutions are better and exogenous chloride load is less for these particular patients. NORAD is better for systemic hypotension, but actually can lead to a long-term medullary damage. Increasing mean arterial pressure to more than 80 is probably better for preventing AKI. So when it comes to diagnostic workup, what all are the things that you would like to use? Ultrasound or USG is the first line imaging modality. Now, kidney size is actually typically measured in the long axis. It is also referred to as bipolar length. Echogenicity is evaluated by comparison with adjacent tissues in the form of liver or spleen. And hyperechogenicity favors diffuse parenchymal kidney disease. Now, what you are looking at are certain Doppler-based resistive indices. You talk about intrarenal resistive index. It's a calculation based on peak systolic shift and minimum diastolic shift. And this resistive index is considered normal if it is less than 0.7. Normal range is age dependent. What we do is you can actually look at changes in the resistive index to help you titrate norepinephrine in titrating to optimal mean arterial pressure in ICU patients. It is influenced by cardiac output, heart rate, your PaCO2 levels, your PA2 levels, intra-abdominal pressures, and renal interstitial pressures. It needs further studies, and you need to have a contrast-enhanced ultrasound to document cortical. When it comes to role of CT MRI, non-contrast CT is gold standard for urolithiasis and pyelonephritis. If you do a triphasic one, it will actually allow assessment of GFR and renal blood flow. Now, MRI doesn't have a role in diagnostic workup. Indications of biopsy include persistent loss of kidney function. Conventionally, it is said that an acute tubular necrosis can persist up to 6 weeks. That is the usual time window that is given to them before actually subjecting these patients to biopsy or proteinuria of more than 3 grams per day. So then we look at it in terms of role of CT MRI. You got a history wherein the patient is predisposed to AKI, then you get a social history, recent travels, any history of exposure to nephrotoxic agents, exposure to waterways or sewage systems and rodents, pregnancy or malignancy. Then clinical examination wise, you look for any extrarenal involvement or infection or sepsis, volume status, then you give attention to skin and periangular lesions, mouth and nose ulcerations, alveolar hemorrhage, abdominal syndrome, as well as intra-abdominal pressure. This is all what you look on clinical examination. Then you do an echocardiography and try to rule out a RV dysfunction or an LV dysfunction, valvular dysfunction, or signs of endocarditis. When it comes to renal ultrasound, you are looking at your kidney size, you are looking at features which are suggesting CKD. Then you can look up any obstruction in the form of leading to a post-renal AKI, and of course, overall renal overall perfusion. When you do a renal urine analysis, you look at proteinuria, hematuria with or without the morphology of RBCs. You look at leukocyturia, eosinophiliuria, cytobacteriological examination, and you look for presence of cylinders. Blood testing wise, you look for hypercalcemia, liver dysfunction, metabolic acidosis, any cytopenias, specifically platelet counts and DIC, hyperproteinemias, uric acid levels, and creatinine kinase. So when it comes to renal transplant recipients with a fresh AKI, what you should not miss is renal hypoperfusion. Look for absolute hypovolemia, cardiac dysfunction, and renal vasoconstriction. And try to rule out your renal graft artery stenosis with or without renin-angiotensin system antagonist and hepatorenal syndrome. When it comes to a post-renal acute kidney injury, try to rule out an empty bladder or dilated bladder. Empty bladder comes with urethral dilatation, fibrosis of uretrovesical anastomosis, obstructive lithiasis, fungal ball, and papillary necrosis. Without urethral dilatation, it could be secondary to pilourethral stenosis, compression with or without superimposed infection, or it can be because of a dilated bladder, secondary to a low obstacle or cervical-uretral obstruction. Wait. So when it comes to intrinsic AKI, A is either acute interstitial or tubular nephritis, secondary to acute ejection, sepsis, acute pyelonephritis by BK virus nephropathy, and of course recurrence of oxalate deposition. When we talk in terms of glomerular diseases, they are mainly characterized by high proteinuria, namely albuminuria. You can get recurrence of underlying nephropathy in these patients. They have a de novo glomerular injury, such as the humoral ejection and membranous Jain. And when it comes to vascular disease, you are basically looking at hyperacute ejection, you're looking at herpes infection, and you're looking at recurrence of vasculitis. So this is basically, randomized trials which have investigated the timing or intensity of renal replacement therapy in septic patients. When it comes to PINE, they studied subgroups of severe sepsis or shock, and you did early CVVH, 25 mils per kg per hour versus no CRRT. Timing was within 24 hours of first organ failure. Results, CVVH did not limit organ failure. Now, Zhang, when we comes another trial, Moir and Icorus, now all of them, when you look at it, they have intervened in the form of CVVH, CVVH, CVVHDF, and various flow rates. So when we look at renal study, when we look at data in ATN, there's been no benefit of subjecting these patients to early renal replacement therapy. And the flow that is recommended is 20 to 25 mils per kg per hour. What about dialysis catheters? Ultrasound guidance is preferred. Both femoral and jugular are acceptable because they have similar rates of tip colonization and CR by SI with comparable catheter dysfunction rates. Avoid subclavian, can give rise to stenosis. Catheter tip colonization is sometimes higher in femoral locations in patients who have got a higher body mass index and those patients who are not on chlorhexidine impregnated dressings. Now, heparin-based locking used to be a standard, but there are greater chances of hit and bleeding complications in those patients who are susceptible. In catheters, which are less than 25 centimeters on length or lower flow capacity catheter dysfunction, or have a lower flow, catheter dysfunction and decirculation is higher with a femoral location. If you place these catheters in left internal jugular vein, it predisposes to a greater catheter dysfunction, and patients with femoral catheters can be safely mobilized for physiotherapy. What about pressors? Using one pressor over the other, non-inferior to other in general, noradrenaline or norepinephrine can restore blood pressure and transiently improve renal function with fewer side effects than alpha dose dopamine. However, it can enhance medullary hypoxia and lead to long-term injury. Maintenance of mean arterial pressure more than 80 is supposed to give a better effect or is more beneficial for subsets who have AKI in terms of perfusion. Now, what about renal replacement therapy? As I told you, timing, dose, modality, these are key issues. Commencing early can improve outcomes theoretically, but none of the trials that have been there have documented that early versus late paradigm, whether it is actually solved or not. But if you do it early, it will lead to inadequate antibiotic exposure, and it can also give rise to adverse effects of an extracorporeal circuit. Now, CRRT is recommended for hemodynamically unstable patients. ELAINE trial, one of them has shown benefit for early intervention, but there is no difference of outcome with different levels of treatment intensity, ATN or renal trial. Currently, the standard of practice is 20 to 25 mils per kg per hour of removal in terms of solute clearance. Optimal timing and cessation timing of renal replacement therapy remain uncertain. Modalities, CRRT and intermittent renal replacement therapy are complementary to each other. It basically can be used interchangeably depending on patient characteristics and ICU-based operational characteristics. CRRT, whatever said and done, is preferable for acute brain injury and permanent hepatic failure. And SCUF, slow continuous ultrafiltration, can be used for diuretic unresponsive cardiorenal syndrome or when your main objective is fluid removal only. One term that you all need to know about furosemide stress test. What is a furosemide stress test? It is used to ascertain whether the tubular function in a patient of oliguria is intact or not. It requires an intact nephron, and you need to have intact functions of loop of Henle and PCT. So basically what it does is it allows us to identify those patients who have intrinsic renal failure, but who will not benefit from further fluid loading. So how is it done actually? So an appropriate candidate for furosemide stress test has to be adequately resuscitated patient, one who has got persistent oliguria, wherein it is doubtful that a fluid or vasopressor or inotrope challenge would help. You do a furosemide stress test. If the patient hasn't received furosemide before, you give a 1 milligram per kg IV bolus. If the patient is received it before, then you give 1.5 milligram per kg IV bolus. If the urine output is more than 200 mils in 2 hours, then the patient is deemed to have passed the stress test. So it is most likely to be a pre-renal oliguria. Whereas if it is less than 200 mils in 2 hours, the patient is supposed to have failed the test and it is more likely to be an intrinsic renal failure. So with pre-renal, the management lines become in terms of replacing urine output, attempting further hemodynamic manipulations to improve urine output, and it can be a useful measurement of organ perfusion in that type of a setting. Whereas for intrinsic renal failure, you need to give additional fluid, vasopressors, or inotropes, which are unlikely to improve urine output. And here, urine output doesn't remain a meaningful measurement of perfusion in these particular patients. So there are certain take-home points here. Etiology of acute kidney injury is multifactorial. Early diagnosis and treatment gives better results. Scoring systems are available for identification and stratification. If you have to have a diagnostic armamentarium for localization as regards to what is the type of defect that you are dealing with, it can be multi-pronged. And most of these patients do well if above rules are applied. Thank you. So somebody has asked actually, what is the role of cystatin as a biomarker for kidney injury? So I have told them that it's a linear relationship with kidney function. That's what, as the kidney function improves, the levels go down. Oh, sorry, sir, I should define it differently. This actually, I put it as inverse. Okay. So as your kidney functions improve, your cystatin levels go down, and as your kidney functions worsen, the cystatin levels go up.
Okay, sir. And also, I have a small announcement to make that all the aspirants are requested to check their portal. We have uploaded a mock exam. Please be done with it before 26th January because on 27th we will be having a debriefing session on that. Thank you.